Good morning. We're the DataVision Avengers from the University of Notre Dame. Today, we'll be presenting about racial inequity in respiratory care across Northeast Kansas. So for a research overview, our team analyzed roughly 390,000 respiratory encounters at Stormont Vale Health between 2022 and 2025. The question was simple. Do racial disparities exist in how respiratory care is accessed? And if so, how deep do they run? The answer is unambiguous, and what follows is the evidence. So for a national context, nationally, Black Americans are 1.5 times more likely to have asthma, 5 times more likely to visit the ED for it, and 3 times more likely to die from it. A 2024 study in hospital pediatrics found that Black Medicaid enrolled children have 2.42 times the odds of an asthma ED visit compared to white children, after adjusting for age, sex, state, and rurality. A separate CDC study confirmed that this gap is not narrowing over time. Our question was whether these patterns extend to Northeast Kansas. So for the Kansas context, Kansas is one of 9 states that has not expanded Medicaid, leaving approximately 39,000 adults in a coverage gap. Expansion has been proposed 7 times since 2019 and blocked each time. In the Kansas City metro, Black residents are 15% of the population, but account for 47% of asthma ED visits. This is the policy environment Stormont Vale operates in, and the environment their patients navigate daily. So for our data set, from SVH's 7.6 million encounter records, we isolated 390,000 respiratory encounters across 34,000 patients. We merged this with social determinants with screenings, provider data, and Census Bureau socioeconomic indicators at the tract level to examine not just clinical patterns, but structural context.
This is our central finding, which is ED reliance by race and age. The horizontal axis is patient age, and the vertical axis is the percentage of respiratory encounters occurring in the ED. The red line are Black patients, and the blue line are white patients. And the magnitude is striking. In childhood, 80 to 90% of Black respiratory encounters occur in the ED, compared to 50 to 60% for white children. By age 30, white patients cross below 50%. They transition to outpatient care, while Black patients never make that transition, remaining at 60 to 70% into middle age. The dashed lines mark age 26, which is when ACA-dependent coverage ends, and age 65, Medicare. If insurance were the primary driver, we'd expect convergence at these thresholds, but we don't. The gap persists through both, pointing to something more structural than convergence alone. On the left, our age-standardized ED reliance index shows that the ED is the primary care modality for Black respiratory patients across most age groups. White patients fall below 50% by their early 30s. On the right, the diagnosis mix reveals that asthma and COPD, which are conditions clinical guidelines should say are managed primarily through outpatients, appears disproportionately amongst Black patients. The population with the greatest need for ongoing outpatient management has the least access to it. In total, 69% of Black respiratory encounters occur in ED versus 39% for white patients, who receive nearly half their care in outpatient settings. The conditions are the same, the severity overlaps, but the care setting diverges sharply by race. This is a system-level finding. And so we decided to test whether smoking, seasonality, or time trends explain this gap, as they are confounders, but they don't. The disparity is identical across never smokers, former smokers, and current smokers. It's symmetry across all 4 seasons, and it shows zero convergence from 2022 to 2025. This is structural and stable. When we stratify by smoking status, the gap holds significantly. Never smokers, former smokers, current smokers, the Black-white disparity is virtually identical across all 3. Behavior doesn't explain this. The same story goes on for season. In the winter, spring, the summer, and fall, the gap is symmetric. This isn't driven by flu season or pollen. And year over year, from 2022 through 2025, there's no convergence. 3 years of data and there's zero improvement, and this is structural and it's stable.
These maps show respiratory ED rates by census tract in Shawnee County. For the white patients, ED reliance varies moderately across tracts. For Black patients, the map turns uniformly dark with high ED reliance in nearly every tract. The gap is not concentrated in one neighborhood, it's countywide. Across 46 tracts, the median Black ED rate is 66%. The median white rate is 37%. And when we go into the social economic context, when we overlay census data, the pattern crystallizes. The tracts with the highest ED reliance are the same tracts with the lowest incomes, the highest poverty, the highest percentage of Black residents, and it has the highest uninsured rates. And with these factors, they compound. A patient in high poverty, predominantly Black census tract, faces converging barriers that our ED data directly reflects. And so, going to our key findings to summarize, the Black patients show about 60 to 80% ED reliance for respiratory care at every age. The gap survives every control: smoking, severity, and season and time. And so these conditions driving it are outpatient manageable, and it hasn't improved in 3 years. And so what my recommendations would be is our recommendations are to expand the outpatient respiratory access in specific high reliance tracts that our maps identify. So with this, we would deploy community health workers for pediatric asthma home management. We would establish after hours respiratory clinics. And when we go at the policy level, we would also go into Medicaid expansion. So that would be remaining the single highest impact intervention. And so with that, this should be able to close the coverage gap for about 39,000 Kansans. And with this, every recommendation maps to a specific finding. Thank you very much.